we've had a client very recently that has situs inversus, and his heart is actually on his right side and his liver is actually on the left side. And we've done all of our assessments on him, and he is in the same pattern as any other average, normal human being.
Hello, everybody, and welcome to another Polestar Pilates Hour. Today, I have two special guests and part of the Polestar family for many years. I have Dr. Sarah Petrick and also Donna Byrne. All of us sort of in the dance medicine world and in the physical therapy world and the Pilates world. And very interested in the topic they're bringing to us today, which is postural restoration. You know, we talk a lot about posture. We talk especially about dynamic posture that they are experts in. And we're looking forward to having both of you on the show today. So thank you for joining me. You're welcome. You're welcome. Let's go ahead and dive in. We've got a lot of topics to discuss today, and particularly looking at this whole idea of postural restoration. Everybody's sort of fixed on it. And even going back to the old days in our physical therapy books that show the picture in Kindle and Kindle of a static posture, and oh, everybody has to look like this, and this is what a normal lordosis and a normal thoracic kyphosis look like. And we've come a long ways, thank goodness, from those images. Both of you are physical therapists. Both of you are Polestar trained Pilates teachers, and I believe you're both certified with NCPT. Is that correct?
Yes.
Donna is. And thank you for doing that, because I think it's important. Like a lot of times, those of us as physical therapists go through training, we don't feel like we need to do the certification on top of the training because our license bears a little more weight. But I think it says a lot when we actually go through and take a difficult test. And of course, the Polestar graduate exam is not easy either, but the idea of being able to show the competencies in not only being a physical therapist, but also in the Pilates industry, I think it adds a lot to the clout of us being able to talk to our group that's with us today. They're all here about that. Couple of things. When we talk about one of the things I really enjoyed reading some of the things that you have written is the idea of the right of being asymmetrical. And I'd love to have you talk just a little bit, and I don't care which one of you goes first with it, but the idea of respecting asymmetry while still optimizing alignment. And that was something that sort of stuck out to me that I would love to hear you in your own words. Maybe share with the audience, what does that mean to you in your own words?
Well,
go ahead, Donna.
The biggest tenet of the Post Restoration Institute and Rebalance Pilates is that we recognize that all human beings are asymmetrical, but we are in this right dominant pattern. So we are in this asymmetrical pattern, not just physiologically. Physiologically, we have a liver on the right side and 3 lobes of lungs on the right, and a heart on the left side, and only 2 lobes of lungs on the left, compressing that flattening that left diaphragm. So physiologically, we're asymmetrical, but more importantly, neurologically, we're asymmetrical. The left hemisphere of our brain has more neuromotor controls that controls the right motor dominance. So our left hemisphere of our brain makes us all right motor dominant, whether we're right-handed or left-handed. Neurologically, we are driven to that side, and physiologically, we're driven to that side.
Interesting. Sarah, any thoughts on that from your point of view, as far as sort of like a right to be? I felt so good reading and thinking, like, we are asymmetrical animals, and yet we can optimize posture. Talk a little bit about what does it mean optimizing posture to you?
Well, actually, we sent you some PowerPoint slides, and within it, yeah, we do have these tendencies that are asymmetrical. I think, first of all, how freeing is that to know that you're never going to be perfectly symmetrical? we have permission to be human, and it's part of being human. But you can get off kilter in and past a certain threshold where you no longer really can have good balance in your system. So that's part of the reason why Donna and I, we created our own partnership and called our business Rebalance Pilates, because we don't expect people to get perfectly aligned. That would be lovely, but that's also not living. We don't stay perfectly square in our hips and shoulders while we move. We need to be dynamic human beings, but we want to try to maintain this balance where we can still shift and move on each side in a relative ease and flow that makes it easy for us to live and be active and have variety to our lives and movements.
Yeah, I heard a good phrase not too long ago, probably about maybe 4 or 5 years ago, but it was perfectly imperfect. And I always thought of like, that's such a great phrase because, you know, whether we're talking about physical, emotional, spiritual, like as human beings, we can be perfectly imperfect and we can accept ourselves and continue to grow and improve ourselves. And, you know, all of us coming from the dance world, I mean, we were taught that there is perfection, that there is a right way to do a pirouette. There is a perfect alignment. And I think I found that challenging. I remember talking a lot about this with Eric Franklin, who's also sort of in the same boat as us, of working in the dance medicine world and working with dance educators, being able to find a place that the body can do its function at its highest level. As I look back and I think of, you know, the training that you both came through with the Postural Restoration Institute, can you give a little bit of a history of that training as what led to you wanting to start Rebalance Pilates and, you know, having the other things that you had underneath your belt with dance, physical therapy, Pilates? I know, Donna, you did Pilates first, and then you did the Postural Restoration Institute, and Sarah, you were the opposite. Both, I think, brings a really nice twist to your union in Rebalance Pilates. Talk to me a little bit about that process of your training. What did Postural Restoration Institute involve for you in your training? I don't know if everybody's familiar with that or not.
Well, when I went to my first posture restoration course, it was a course that was all about treating the sacrum, the sacral instabilities, hip impingement. And I went to that first course and I was like, what kind of pattern are they talking about? I've realized after I got somebody on the table, I could really see this is a pattern that I'm seeing all the time. And they actually gave it a name, the left anterior interior chain pattern. And I realized that I can facilitate in the Pilates world. I can start finding a hamstring and finding a left internal obliques to work with that left hamstring to allow my weight to shift to the left, to allow get more airflow in that right side. So the end goal, I can be balanced and reciprocal, but I have to bias things over to the left instead of doing everything all at the same time. And that's what started my journey with posture restoration.
Cool, cool. Sarah,
Yeah,
anything different?
my journey started, well, I was lucky enough to get exposed to it in PT school. And to be honest, I went into PT school because I was fascinated with movement. But I had really not any history with injury until I was in PT school. And, you know, you're always testing each other out. And being from a dance background, I never had any flexibility issues or strength issues. Like a lot of those just kind of fundamental objective tests I could surpass. Postural restoration, when I got just an hour of exposure to it, they had some different objective testing that really showed like, oh my gosh, I'm failing at a few things. Like, and I thought I was super strong and I'm mobile, but that doesn't mean I was using the right functional pattern of movement to get the job done. And so really exposed some of my own, I don't know if you want to say quote failings, let's not call them failings, let's call it being a human, but also being a human that's trying to figure out how to do all the things that I want to do, but I haven't figured out the most efficient and best way to go about moving and shifting and doing certain other activities.
Yeah. You know, Shelley and I have been talking a lot about the concept of failure to learn and not making such a negative connotation out of it. So I do think that, you know, the learning process of human movement is by trial and error. And that's how little children learn how to move. That's how we should probably learn how to move as well. You guys have a presentation that you wanted to share and just some things to talk a little bit more about it. Let's move right into that as Melissa pulls up the slides. There is a question that came in. And this is from Yasmin Regalado and says, hello, I've heard different trainers and coaches say it is okay to add 1 or 2 extra reps on the weaker side. Can you share your thoughts on that? So before we start going through the slides, either of you have any thoughts on Jasmine's question?
Absolutely. So if I oftentimes tell people when I'm teaching a course, if I test somebody's hip strength and it's a 4 out of 5 on one side and a 3 out of 5 on the other, if I strengthen both sides the same amount, I'm still going to have a differential between the two sides. And that's just strength. We're going to talk even a little bit more in terms of movement dominance as well as we get along in this presentation. But certainly working on certain movements that are more challenging on one side it's going to be important to work on that side more than the other side, so you can create more relative balance between the two sides. To be honest, weakness or strength, that's one thing to look at, but you can have a relatively, it's kind of nice sometimes to have someone who needs to build some strength. If somebody's really strong in a very asymmetrical pattern, you're going to have to do a whole lot more of strengthening and working, not just muscle strength, but neurological patterning of doing the opposite side to have more balance. So sometimes that's even a little bit easier when someone's coming in a little more deconditioned.
I see Donna and see that. Donna,
I just want to add, yes, these people, we as humans need more sensory motor awareness of the other side, which is going to take more repetition to really sense the ground on that side, sense being aware of our left periphery, being aware of the side that we're drawn away from. We're drawn to our right side. So we need to create that sensory awareness. So it's a neuromuscular construct, really. We talk in terms of strength because that's the world that we live in sometimes, but it's really that neurosensory, neuromotor awareness of the less
Awesome.
dominant side.
Great. Jasmine, thank you. Jasmina, thank you for that question. On you go.
By the way, I just have to say shout out to Donna. It's nice to see you.
Donna Bear?
Yeah, Donna Bear's on. Anyway.
So Donna Bear and I got certified in post restoration the same year. There were 3 Donnas in our certifying our certification program. Sarah got certified the year before. So, and she started doing Pilates because she took one of our very first courses, PRI integration for Pilates. She got really interested in Pilates and she has gone now to her Polestar certification.
Wow. Thank you for that. Thank you, Donna. Donna and Donna. All right.
So,
yeah. Let's jump into your presentation.
Yeah. So, one of the major things that we're talking about today is that rebalance, we look at the body, that we recognize that all human beings are not symmetrical, which we've already touched on, but both physically or physiologically, neurologically, and habitually. And we base a lot of our work on the Postural Restoration Institute's concepts to strive to rebalance this asymmetry that we see in breath, posture, and movement. So one of the things that we started talking about at the beginning of this hour is talking about posture. And we like to talk about posture and neutrality, and they have a bit of overlap. we actually like to redefine neutrality as not being one static position, like how we used to define it back in the days of just looking at a plumb line and just looking at degrees of thoracic kyphosis and lordosis and having this one idea of this picture perfect position. Instead, we like to think of it more as a zone. And this zone is actually a transitional zone. So if, for instance, we have this image of a box here on your screen. And if you were to stand like in the middle of that box, when you shift over onto your right foot, your center of gravity goes over to the right, and you shift over to the left, your center of gravity goes to the left. And if we shift forward onto your toes or onto your heels, you're going to shift forward and back. And we can even rotate in there and twist. But when we go and shift from side to side, forward and back, and multiple planes of motion, we want to be able to shift through this neutral transitional zone instead of always keeping our weight forward or in more of an extended position, or even collapsed too far back, or as we've already alluded to, and Donna discussed, that there's a dominant pattern of really preferring to be more shifted over and centered over your right side rather than your left. And this neutral zone also happens to be a really nice parasympathetic restful state. So there's certainly a lot of people who get around trying to get picture perfect posture, but to me it means nothing if when you get that posture, you're tensing up your neck, you're tensing up your back, you're tensing up your hip flexors. That is not a nice neurological place of rest. And so that's what we really want neutrality to be, is a good home for you to return to when you're shifting back and forth. We've got a nice place in the middle we can rest and enjoy. And then to carry this on a little bit farther forward, we're going to talk about posture. And like I said, there's a little bit of overlap in here in the sense that posture is not simply a choice. So you can't just think yourself into having a perfect spine that is perfectly neutral or perfectly has balance just by trying to force yourself into some sort of idea of what that looks like. It really comes from within. So it's involving the neurological system. It also involves the respiratory system. It involves your sensory systems. So it involves a lot of combined influence of multiple body systems. And this posture also isn't static, like I've discussed with neutrality. It's dynamic. And so with that, I wanted to go over some tri-planar motions. If you're sitting at home, you can do sitting or standing, but we like to work on kind of 3 main planes of motion, although recognizing that really there's multiple planes of motion, even more than that. So I like to make sure that we can transition between all of these different movements. So I'm going to just angle my camera down a little bit. Let me see if I can do this a little bit better here. So if you're sitting, I'm going to just kind of squat down a little bit, but if you're sitting or standing, we have more of a rotational plane of motion. But when we walk and we shift through our hips. And so you can slide one knee forward and one knee back. So if you were like to say you're going to stand on your left leg, you should, in order to do that, center your pelvis over that leg, and your pubic bone needs to get in line with that knee and foot, and your chest needs to center over that, and your head. And when we walk, we also rotate up here. So there's some rotation that happens through your hip sockets, and there's some rotation that happens in that thoracic spine in order for you to properly shift and center your 3 body cavities over your legs. And that would be in the transverse plane. Now, your neutral zone is going to be that transitional zone in between there. But if you have a habit or a preference to always liking to shift to one side more than you shift to the other side, your zone is going to shift more to the right. And if that preference keeps getting more and more lateralized, then tissues start to break down and we have some issues. Now, this is the transverse plane. We also have a frontal plane, which is more like hip hiking. And I'm not going to show you my block, but it's not just hip hiking alone, though. So I'm standing on a block that you can't see. I'm in a small room, but we have a traditional hip hike type of motion. You can do this sitting as well. But it's not just a pelvis that moves up, but a thorax that also needs to drop down on that side so you can stay standing over that leg. And your head also will right itself. So all three cavities here have to rotate and move in order to balance yourself on one leg. And we have a preference for one side versus the other on that as well. So we're going to keep that in mind. We're going to talk a little bit more detail about that asymmetry in a bit. But knowing that we have that frontal plane and that needs to be balanced is really important. And then finally, and probably what I should have gone over first, is the sagittal plane. So even just sitting or standing, when you move your pelvis, it moves the rest of your spine as well. So if you were to do an anterior pelvic tilt, it tends to push these ribs forward, which is going to change how you breathe and how you use your diaphragm. And it's also going to change the position of your head. Conversely, if you are in a what I like to call more of a collapsed posterior pelvic tilt, that's going to be problematic, right? But no matter what, whether you move your pelvis forward or back, or you're in the middle, every time you move that pelvis, rib cage is going to move and head's going to also move. So they're interconnected. And we need to balance out all those motions to have a good neutral place of rest and have good posture. And part of that posture also is derived from some other systems. And the primary one we're going to discuss today is your breath, which we know all of us Pilates instructors really appreciate and respect. Yes, Donna, do you have something to add to that?
I just wanted to highlight that we need to manage the sagittal plane first, because if you're stuck in this extended position and you're locked up in this sympathetically driven sagittal position, you are not going to be able to move and rotate and in the frontal plane, in the transverse plane, in multiple planes if you're rigid in the sagittal plane. So we always want to manage the sagittal plane first, and then be able to learn how to shift and to rotate, because that's functional movement, that multiplanar movement. But it goes back to, I always think about this with the scoliosis courses, like we really have to manage the sagittal plane with the scoliosis, otherwise you just go farther into the path of your curve.
Yeah. And so the next PowerPoint slide just is a demonstration of some of those motions. I like to call these like my snowballs, because I'm from Minnesota. So we are well acquainted with snowmen, and we're all like snowmen or women or snow people, but we have 3 snowballs, but they all need to end up to having the ability to shift and balance over each other on each leg. But when you move one, you're going to have to move all of them. So they all kind of glide and flow together. So that's all that slide is. That's a fun exercise and kind of talking about range of motion in the spine and in the body. But underneath it all, and even more fundamental, is really respecting breath. And this at the Postural Restoration Institute, we like to talk a lot about this thing called the zone of apposition. And it kind of has this, I don't know, magical tone to it. But if you look at that picture of the diaphragm there, and it's kind of an exaggerated diaphragm, but and if you can picture a rib cage around it, I put some white lines there. When you have a zone of apposition, what that's referring to is the amount of fibers of the outer side of that parachute shape that are apposed, meaning up against the inside of that rib cage. And so that zone of apposition is how much fibers you have up against the rib cage. That is a nice domed up diaphragm. And when we exhale, the diaphragm domes up. You should get more zone of apposition. The muscle relaxes. If you have people who do not have a good zone of apposition, their ribs will tend to be more flared because their diaphragms will be flatter, more contracted, and they're usually pulling them forward. And before we then move on to the next slide, let's appreciate, as you're looking at this picture, it's a little faint, but this red diaphragm, we have attachments that go into the spine. And I'm going to say that for emphasis, the diaphragm attaches to the spine. And so it can majorly affect the spine. And you have fibers that attach on the left side, and you have more fibers that attach on the right side. And yes, you actually have more fibers that attach on the right side and lower down. And so there's definitely an asymmetry already, going back to asymmetry, to the diaphragm itself. And so you can imagine that the diaphragm will have an asymmetrical pull on that spine, further emphasizing these tendencies for lateralization of the human body. And we're now looking at like a sagittal view. When we have a nice zone of apposition, which is on the right-hand side of your screen, the diaphragm can actually have a tractional pull on the spine. So it can pull up and help decompress the spine from above. If anyone knows about back issues and this thing called traction, I like to say that we can traction the spine internally with a diaphragm from above, and then your other traction belt comes from below. As you can see, the other line, you can see I put a little yellow arrow. There's a little bit of a hamstring there. And the hamstring can actually help stabilize the pelvis as well from below. So if we keep the pelvis nice and stable as we dome up the diaphragm, we can actually create more space and more decompression of the spine. That being said, if you lose this magical thing called the zone of apposition, if the diaphragm starts to get flat and it starts to pull forward, it can actually pull forward on the spine and create more compression on the spine. And it also happens to attach at the levels where this, this pesky muscle that gets a lot of bad rap sometimes, the psoas does. The psoas attaches to those same levels. So if you can imagine the diaphragm having an anterior pull on the spine would also place the psoas in a position where it's going to go, hey, I can also join in the party and pull forward on the spine. And guess what? I attach to a hip, and I can also have an influence on that pelvis and anteriorly start to tilt the pelvis. So what we see is when we have a lack of good diaphragmatic zone of apposition mechanics, then we're going to get more of an anterior extended posturing of the spine. So then looking at the diaphragm a little bit closer, we've got this image courtesy of the Postural Restoration Institute. They let us use it here. This is a image that shows some of the patterns. You can see that the left diaphragm fibers on that left side are smaller. It tends to be flatter, and it starts to anteriorly to pull the spine forward into more extension. And then the left psoas actually has more of a pull anteriorly in the sagittal plane, and can start to extend the spine more on one side. Now, if you start to extend the spine more on one side with the psoas, that spine is going to start to turn and orient to the right, which happens to be our dominant side pattern. So most people tend to orient their spine more to the right. And we also have changes because of this asymmetry in the diaphragm. We also have changes in airflow patterns. So that's why I put this x-ray up. I always say you can tell an x-ray yes by looking at the shadow of the heart. So you can see that the heart is looking like it's more on the right-hand side of your screen. That's the left side of this x-ray. But you can also look at where the diaphragm is. So you can tell that on that left side that the diaphragm's lower. You can also tell that there's more air in that cavity. And then the other side is a little bit higher. And so, Melissa, if you just click on the screen, I think of that left side is having this big inflated balloon. And then the right side, because that diaphragm's more dormed up, it has less air expansion in it. And so what we want to do with respecting this asymmetry is we don't want that asymmetry to get too off, too asymmetrical, where it really starts to impact us functionally. And so we strive to try to balance that out. And Donna is going to end up showing you some pictures of how we managed to do that in a bit. This is one of my clients, and I just put it up because you can really see. She was laying down one day, and I was like, "This is the perfect picture." So you can see that she's got this like sort of necklace thing on. And I will tell you, I actually tried to put it center on her body again, and it just sloped back to the right. And part of that is because she's laying here and she's really poor at getting good airflow in her right chest wall. And her left side is bad at getting the air out. She has a poor left zone of apposition. So she needs to get a little bit more doming of the left diaphragm, which is never going to be as good as the right, because that's how we're made. But if it's really extreme, it can really start to offset things and become a problem. And this asymmetrical airflow can result in asymmetrical posture, but it also results in asymmetrical movement patterns. You also might notice that her knees look like they're different lengths or heights. She does not have a leg length discrepancy, guys. She has a spine that's rotated.
Thank you, Sarah. What I wanted to mention about the drawing of the diaphragm, and that was, Sarah did say that was, we have permission from the Posture Restoration Institute to use that drawing, but the central tendon of the diaphragm of our right hemidiaphragm is stronger and thicker and longer, and it attaches lower on the lumbar spine, which starts that spinal orientation to the right. When I took anatomy trains last year, the year before a dissection, I kept asking, can you point out that? And you could really barely see the left crura of the diaphragm. The right was so much thicker, you could barely see it on this specimen. So that was so cool to see. And also you could see just that big liver sitting over the right diaphragm, and the pericardium and the heart pressing down, further flattening the diaphragm. So we see this in real life all day long. Once you start seeing this pattern, you can't unsee it. But this is one of my favorite pastimes, going to art museums and saying, oh, look at, they're in their pattern. He's definitely in this right mid stance pattern. His weight is on his right side, and he's got his left trunk orienting to the right, because if he has a spine orienting to the right below the level of the diaphragm, the rib cage has to counter rotate to the left. Otherwise, we'd all be walking in right circles all the time. And that's a normal pattern when you're standing on your right leg. When you're standing on your right leg, your spine is oriented to the right, rib cage counter rotates to the left, head has to turn back to the right and side bend to the left, so we see the world level. That's normal on the right side. It's just not normal when we're standing on the left and we don't fully orient to our spine orienting to the left and our upper trunk rotating to the right and our head side bending to the right. We stay in that right dominant pattern. And that's what I look for in art all over the world when I can.
Yeah, I'm really glad you said what you said there, Donna, because look, I like these pictures that you put up, because they're not all people standing on their right leg. The two on the right hand side are standing on their left, but their pelvis is turning to the right. And when you stand on your left leg, you should be trying to center your pelvis over your left. So it should be turning slightly to the left. So they're standing on their left leg, but their spine is still acting like it's standing on their right. And just a note, because I saw this in the chat, I know Donna, I think, mentioned this earlier, but this dominance does not have anything to do with right-handedness necessarily. It has to do with right dominance from a brain and motor development standpoint. So we have more neurological motor centers on the left side, which help control the right side of the body. So we have more dominance for the right side. Even left-handed people have dominant patterns on the right-hand side. And I think I had one other, someone asked about the picture of my client. She does not have scoliosis at all. And she just is a very obvious, you can really see her asymmetry in her airflow in that picture. But you'll see it in more subtle ways as well. Start just looking at people's lower ribs when they lay down. More often than not, that the left lower rib cage is more flared up than the right. You'll see it all the time.
So we have mentioned many times that we are not symmetrical physiologically, neurologically, and habitually. And I just wanted to go back to that, to reference that picture of the X-ray when Sarah said, you know, that this X-ray, the heart, you can see the heart, that's how you know it's the left side of the body, because you don't have that heart on the left side, you know, the liver on the right, heart on the left. But we've had a client very recently that has situs inversus, and his heart is actually on his right side and his liver is actually on the left side. And we've done all of our assessments on him, and he is in the same pattern as any other average normal human being, because the neurological affect trumps everything else. It really helps drive us over to that right side, and the physiologically weights us over on that right side. But even if we're weighted on the other side, the neurological influence takes over. And it was very cool to see, because not many people will really get to see a person like that. So there's very few people like that, but we happened to be introduced to him. So this asymmetrical diaphragm, asymmetrical breath, asymmetrical posture leads to asymmetrical posture and movement patterns. And as Sarah said, one of the greatest influences is really breath. The position of our diaphragm and the ability of our right abdominals to support our right diaphragm to help push air into that left side, that airflow in that left side also pushes us over to the right. So we try to facilitate a left diaphragm that's going to dome up using your left internal obliques and transverse abdominis to internally rotate the left rib cage. So you shifting to the left, using that left hamstring to stabilize the pelvis to promote more airflow in that right side. So we can, and the end goal, have balanced reciprocal motion. So this shows the picture of the diaphragm, and that's a drawing from our friend Mikey, who did these drawings with us, that shows the spinal orientation to the right. So you can see how even the navel is pointing a little bit more to the right, and that rib cage counter rotating to the left. That is what we call, or what is called in the Posture Restoration Institute, a right, we call it the right mid stance pattern. In posture restoration, it's called the left AIC pattern. And that counter rotation of the trunk to the left, we call the right mid thoracic stance pattern. And in posture restoration, it's called the right brachial chain pattern. So all of our terminology comes, all of our science comes from the Posture Restoration Institute. Just to be clear, they this is where we didn't figure this out ourselves. We just took it and applied it to the Pilates world. And this shows the position of the pelvis with that left hemipelvis being forward, that nominate rolling over that left femur. And Brent, I loved when you were talking about the pathology of the hip. I'm gonna grab my pelvis here, because I love when you talked about that, when you said, we're not talking always about how the femur is moving in the pelvis. We're talking about how that pelvis is moving over the femur. And I was like, great, that's what we talk about all the time. So this stronger central tendon of the diaphragm on the right side orients our spine to the right, draws that left pelvis forward into a flexed, abducted, and externally rotated position, while that right pelvis is in a posteriorly rotated, internally, an adducted position. That's that right mid-stance pattern that we see. And that hamstring attaches, that's what's on the drawing there, the hamstring attaches to that left sit bone, and that sometimes that hamstring will be taut because the pelvis is forward, but sometimes in the Pilates world, we really see it's overstretched because it should be taut because that left pelvis is forward. But if it's not, we know that they've compensated somehow to get their, knee to their nose, to get their legs past 90 degrees. So that is the position of the pelvis, and that is normal in that right mid-stance pattern. What we want to train is, let's get over to that left side. Let's sense what it is to mean to be on that left side. Let our brain say, oh, it's safe on my left side. I don't have to spend all my time on my right side. I need to go to my left side half of the time.
Question, Donna, when, we talk a lot in the manual therapy world and did for many years, and now looking at a lot of the literature coming out in the myofascial world and the biotensegrity world, is the observation we have of the asymmetry of the pelvis in standing, looking at things that we would classify in the past as an anterior pelvic torsion or a torque. And I remember making jokes with friends of mine down in Australia that we said that everybody in the northern hemisphere has a left anterior pelvic torsion, and everybody in the southern hemisphere of the world, all the Aussies, have a right anterior pelvic torsion. Obviously not looked at, but it is amazing that what we see clinically, and this is obviously an observational science that we're looking at with Postural Restoration Institute. It's more of an observation of watching how people move and through our dissections and the things we see and we observe. But the amount of asymmetry we see with this anterior left, posterior right, and that rotation with the flared left rib cage. So I think this is something that we all see every time somebody lays on the reformer or they're getting ready to do some work with the tower bar. We see this asymmetry all the time, and I start to wonder, is this really, as you've been mentioning, it's not an abnormality. This is our normality to have this asymmetry. This is our perfectly imperfect posture. And looking at this and just wondering how often our corrections are actually interfering with a normal functional human alignment versus us actually going in and interrupting it or allowing it to be more diverse in its adaptability to activities. The other question that came to my mind as we were going through this is thinking of how sedentary posture and the amount of it, now we're up over 16 hours a day as the average person's sitting time in the Western Hemisphere, and looking at how that is now impairing what a lot of our observations in dynamic alignment was as a bipedal animal, and now we're a bi-sits bone animal, right? We're not that bipedal all the time. What are some of the things that you're seeing before you finish up here? What are you seeing as far as how sedentarism is impacting alignment? And you mentioned earlier behavior. This is becoming a dominant behavior for us as being sitting. I noticed that Sarah is standing. I think she's standing.
Not anymore.
Oh, it still looked like you were standing. That was a good fake. Anyway, what on that?
I'd like to address the first point first, because I loved what you brought up. This is what we see and what we observe. And in Pilates training, we're learned to observe and say, oh, this shoulder's higher, this shoulder's lower, this hip is higher, this hip is lower. The beauty, the brilliance of the Postural Restoration Institute, we have very objective tests that tell us people are in these patterns. And we do those tests as physical therapists. We do those hands-on tests many times during a session. We'll look at somebody, what position that they're in. We'll have an intervention, a technique we'll perform. We'll make sure that that client will perform their active techniques, that the client will perform. Then we'll retest to make sure that that technique made a change. Because my point is, why would you do anything if it's not making an immediate change? in our rebalance courses, we've taken those postural restoration assessments and made them into movement assessments. So they're active movement assessments where the client can see, one is a trunk rotation test. Do my legs go more freely to the right versus the left? Can I bring my hip into extension and adduct it on one side better than the other? So we really use those objectives, assessments and movement misassessments to drive our programming, right? So the end goal is not to be, okay, now I'm on my left side. The end goal is to be able not to get stuck on the right side, to be able to shift right and left. And that's function. So we'll never auto correct that because of that inherent asymmetry. We'll never be more on that left side. We can never auto-correct it, but the end goal is to be reciprocal and alternating because that's functional movement.
Yeah,
and
we
the
want to be as
habitual part of
balanced.
it. Oh, sorry. I'll let you talk 1 second, Sarah. The habitual part of it, when we are habitually asymmetrical, we tend to sit more on our right side. We tend to stand more on our right side. So that those things that you do throughout the day, being awareness of, oh, I should be a little bit more on my left sit bone, maybe. I'm not going to develop this compensatory breathing pattern, this compensatory positioning pattern. So those are things we talk about a lot, and we certainly do techniques in each of those positions to help get out of that habitual patterning.
Yeah, we're going to be running out of time here in a minute. We
Oh.
have some questions coming up, and I know you have a lot more.
Well,
We'll talk about where people can find a lot more of what you're doing at Rebalance. I did have another, like one of the questions that come to mind. I always like to present research questions to those of you that are out there wanting to do research. And what I would like to see now is, what does the research show that with our left-handed dominant clients and family members, and those of you that are left-hand dominant, is again starting to look and dissect more sort of what the neural behavior is now. Because what you're mentioning is, I'd like to see some more of the research on that, of the hypothesis that the left side motor dominance and looking at how that implies to our posture and our movement. I agree 100% that the physiology, and this is something I love talking about, and Eric Franklin has a whole course looking at movement from the organs. And so when you're moving from the organs and you're looking at moving from the relationship between the diaphragm and the liver, is different than moving between the diaphragm and the pancreas or the stomach, and looking at how we move around the body with breath and how breath facilitates movement and movement facilitates breath. So there's so much in here. And I think one of the key things, and what I want to put out here in the end of our time, we got about 7-8 minutes left, is how we gather new tools, right? How do we gather tools of assessment and intervention? And you've mentioned, just like you just scratched the surface of the tools that you guys use in your Rebalance Pilates. And even though a lot of them come from the postural restoration, so what you've done is you've accommodated them to be able to work inside of the Pilates environment. And I'm assuming in particularly for Pilates teachers. And this is why the same thing we did with the Polestar assessment tool, right? We wanted to give tools of movement assessment and functional assessment to the movement practitioner, not just the medical practitioner or healthcare practitioner. And I'd like you to talk a little bit now about what somebody would expect. What would we expect going into Rebalance training? And what does it involve? What does it look like? But if someone was recovering from a respiratory issue, and their main goal were to decrease their work of breathing and increase lung volume, would you mainly do sideline exercises to bias that? How would you approach this case and progress the client? Great question.
That's one particular exercise, for instance, we will utilize to help establish more of a zone of apposition, or more diaphragm doming, or exhalation using your left obliques versus your right, by using that right arm to kind of shift and rotate and influence the spine orientation to the left and help increase some left oblique work. And we do very thoughtful breathing on exhaling, holding the breath a little bit so you can really sense the abdominals work with your respiratory system as you exhale, and then maintain those obliques internally rotating the ribs, particularly on that left side, as you take a breath of air in to help expand and increase more airflow on the right side. And so we can do it supine, but we can do it side lying. We can do it standing. We can do it in many different positions, but there are ways we can use our limbs differently on each side. We can use a right arm reach. The picture in the middle down below is working on a left hamstring, which that can stabilize the left pelvis, but it can also help influence this left oblique again and help influence more airflow into the right upper chest. And then the other two on the sides are using, one is using the left tricep to help with that left oblique wall as well. And then this other one with the right arm up a little bit off to the side is also trying to help open up the right chest cavity. So we can do it in a lot of different ways. And there's a lot of different muscles that we oftentimes call abdominal buddies, but they can help influence how you're using your abdominals, which and influence them with how they're pairing with your diaphragm in order to improve where airflow goes and where airflow doesn't go. It can also improve how much the diaphragm can dome up and relax. And for a muscle to be more effective, it needs to first be able to relax so it can also contract better. So there's a lot of different ways to approach that.
And so I just want to reiterate, everybody knows that I'm a fanatic about not cueing a muscle directly, but cueing it through load and through limbs and through direction. And that's exactly what you're showing here. So I just want to reiterate, we have to be experts in knowing our anatomy and the anatomy of our clients. So I know some people get a little lazy with that and they just, oh, just get in the right position. It's like, we sort of have to be able to know or see almost with x-ray vision, or maybe an X-ray EMG kind of thing of knowing what's activating without having to tell them what muscle to cue. But I can just see in the positions that you're creating here is that load is creating a proper neurological response to the load. And that's what we're looking for. Donna?
I was saying we use reference centers. So we are talking about, I want you to feel your left heel. I want you to feel your left low ribs. I want you to sense your right arch. So we use those reference centers. That's the only thing the brain can understand. The brain doesn't understand the muscle really. The brain doesn't know what your right or left hamstring is, but the brain understands, oh, I feel that pressure on my left low ribs, my left low back, on the carriage. I can sense my left heel, which is going to facilitate these chains of muscles working together, because we're not ever talking about isolated muscles. And there's so much parallel with Pilates and postural restoration in that way, because we're talking about these are chains of muscles that work together. So we might say, oh, you might feel your left adductor a little bit more in this exercise, but they have to be able to sense what they're doing to actually do it right and get the maximum effect out of it.
And I love that you're getting out of the pure sagittal or coronal or transverse plane. I think this is we're seeing more and more research come out with things like functional patterning and obviously postural restoration and what you're doing. And it's creating, loads, functional loads that are making their own correction internally without us having to say, oh, we're going to strengthen the, pubococcygeus muscle by doing a Kegel. But knowing that putting the body in the right position, the pubococcygeus has to naturally connect to it or the movement doesn't happen. And, my understanding, I did a little bit of research of what you're working on, a little bit into the Postural Restoration Institute, is that you are challenging these different planes and variations to get a more functional organization that is spontaneous. And that excites me.
Well,
Yeah,
we're
well,
so excited to be going to the farm in September, and it's supposed to be a beautiful time of year, Elizabeth tells me.
It is.
So we'll be talking, really, this was just a little glimpse of what we're talking about, but we basically talked about our 4 main principles. And that's the beginning of the course. We talk about the 4 principles of rebalance, and then we go into depth about breath and dynamic posture, but it's a very, very lab-oriented course. So we want to get people moving right away. We want to be able to sense these concepts in their body, because you can lecture all day long, but if you can't feel it in your body, and being dancers, both Sarah and I, like I have to feel it to be able to teach it.
We're
And I
all
think that's
kinesthetic.
very general, generalization for Pilates teachers, because I think that's the same. So our courses are very lab oriented.
That's
Well,
awesome.
one of the things that I've always appreciated about Polestar in the training program is actually having to get it in your body, and you're testing that out. And we feel really strongly that as to be a good instructor, you also need to be into your own body and be able to sense these exercises. Because also that's really important to have a discussion with your clients too. Like, what are you sensing with all these things? Because to really make change in how people move, they have to have a sensory experience. And
Yeah.
so we feel really strongly about giving people, even taking our course, a strong sensory experience that's a little bit different, that you can explore your asymmetries a little bit more in detail, and our tendencies, and try to balance them out a little bit more.
Well, I am so excited with your work and proud of you as Polestar graduates, and bringing new tools and new ways of looking at impacting positively human movement, and motivating people to move and to increase their body consciousness. It's not enough just to do a Pilates class, but how do we transition people into being conscious, moving human beings in the world? And so this is exciting. And again, we're excited for your work. And everybody's listening to this, you'll get the post-production. You'll see the discount code, Rebalance 25. We'll give you the links for that in the post-production code. And thank you both for joining me today. I had one other short announcement to make before we cut it all off. And that is that we had a wonderful workshop last week on Saturday on stenosis. And I'm really excited about the one we're going to have in August. So if you haven't registered for this one yet, we're keeping the price really low for our Pilates Hour, folks. We appreciate your support so much over the years, and just want to let you know that we're going to dive deep. One of the things we realized in the stenosis workshop is that we were really able to breathe while going through some pretty deep material and looking at some pretty complex things, and so much more that we were able to accomplish in those 3 hours. So I hope you'll join me on the dive into movement feet first. That'll be August 17th. Again, it will be recorded, so those who cannot make it on that time, they can also join us. So I want to thank everybody for joining us in the Pilates Hour. The world is absolutely nuts right now, but we want you to realize that the most important thing is that we bring the world physical, emotional, and spiritual alignment. We do that through movement. We bring consciousness to movement. I just beg everybody to be able to bring a heightened consciousness in your clients when you're working with them. And then we can trust that consciousness collectively to make better decisions in the world. Wishing you a very wonderful weekend. And above all things, wishing that you be kind in the world. And thank you again, Sarah and Donna. It was great having you on the show. And we'll see you next week on the Pilates Hour.
So much. Bye.
Thank you.